think in 4 or 5 seconds we should be live.
Yeah.
Yeah, we are live now, madam. You can start.
Super. So, first of all, good evening, everyone. And I appreciate all of y'all who have joined so late at such short notice. But this is a really interesting topic. It's quite controversial because there's so many questions about its efficiency, about its fertility outcomes, about safety, comparison to other treatments, and of course, long-term outcomes as well. So, Jay, I just have two simple ultrasound images, videos to show you along with two different case scenarios. And then I'll just go through the top 10 questions and I think you'll cover, the answers to these questions at the end of these two cases. So this patient is a fertility case, Jay, and severe dysmenorrhea and has failed IUI, IVF, and even one IVF transfer, and has embryos in the freeze. And you can see this is severe posterior wall adenomyosis.
Yeah.
And the uterine length also you can see over here is around 11 centimeters. And the posterior myometrial thickness is around 6 centimeters. Anterior myometrial thickness is 1.5 centimeters. Endometrial echo not so clear. So this is one case.
Yeah.
And would you recommend a microwave ablation for this patient? This is the first case. Now I'll just quickly go to the second case, Jay, because it's a completely different scenario, but it is something we commonly see in our practice. Now,
Yeah.
this patient is a 38-year-old. She's completed her family. Again, severe dysmenorrhea, not interested in a hysterectomy because she's so young. And here, size of the uterus is 10.5 centimeters. And there is again posterior wall adenomyosis.
Right.
Okay, so one desirous of fertility and the other not desirous of fertility, much younger.
Correct. Correct.
So these are the questions, Jay, about ablation. We all want to know because you are doing quite many cases. You have not yet started doing it at our place, but I'm also very curious about the procedure and criteria. I have written all the questions over here. So
Yeah.
I think over to you, Jay. These are the top 10 questions I think all of us want to know about.
Yeah. So if I can start my screen sharing.
Sure,
Okay.
sure.
Yeah. But
I'll just
before I
stop.
start my screen sharing, no, there are 2 or 3 things which I want to tell. See, every new therapy which we do is going to be met with resistance by people who don't do it, is going to be met by resistance from people who don't know how to do it, and it is going to be met by resistance of people who cannot afford it. Okay. These 3 things happens to everything. The same thing happened when we bought the 3D laparoscopy. The same thing happened when we will switch to a robot. The same thing is going to happen everywhere. So that's okay. That is how evolution is. The people who don't evolve with time are the people who are going to be thrown out. Simple. Right? Now, is microwave ablation a new therapy or an old therapy? So the answer is we all were once upon a time reading in our textbooks about microwave ablation of endometrium. Understanding? And we used to think that when you do a microwave ablation of the endometrium, it was superb because the heavy menstrual bleeding would stop off completely. No? And there were a lot of papers available for that. So what typically happens is you will always get a bunch of people who will go only by the research papers because their only job is to write research papers. They actually don't end up operating. है ना? They write papers. So they will, and we all know as medical fraternity, the good amount of bias in all these research papers. These papers are very good if we want to, fool our patients. What actually happens in the operation theater, what actually happens to the patient is what we know when we do it practically. So that is just one thing which I want to add. Now, second, I want to give some credits. See, I was also not doing microwave ablation till the year 2024. In the year 2024, we started doing microwave ablation. So, of course, people who are very close to us, Aarti madam, Shilpa madam, all these people know that we bought the machine, we started doing. But there is a good amount of credit which needs to be given to 2 people. One is an Indian, Dr. Suyash Naval. He came to our hospital when we started doing microwave ablation, and I think it was a very good gesture on his part to come because he's a very dear friend of ours and he helped us set up our system because he has been doing, but he does not do it for fertility because he's not a fertility specialist. And second, I openly want to thank Professor Gong, Professor Xiaoming Gong. He's from China. In fact, he is the one who has been motivated. He's been seeing my work over the last probably 1 year, 2 years or so. And he's been somebody who has been doing a lot of microwave ablations in China. And he was the one who has been motivating me over the last 8, 9 months or so, more than a year or so, to get into this because, like many other Chinese doctors, he is somebody who has been pioneering this technology and he is very good at it. So we have solicited a lot of help as far as setup is concerned from him. And now I can tell you that he is highly, highly appreciative of our work because me being me, I will go down into the wire of every damn thing. And now we have reached a point where we can repair and maintain the microwave ablation machine on our own. Understanding. So having said this, I will start with the screen sharing because I will answer all the questions which Aarti madam has asked. And I think these are the questions which are very important. So Aarti madam, I think my screen is being seen to you, right?
Yes, yes.
Right. So there are two, three important things which we have to understand as far as microwave ablation is concerned. All right. And these are very, very simple things regarding adenomyosis. So let's say this is a uterus, which is an adenomyotic uterus. Okay.
Mm.
This is an adenomyotic uterus, which we typically know of. Correct. There are two important things. No matter how greatly we operate, no matter how greatly we operate, and Dr. Aarti will agree to this, we are never able to clear off the entire adenomyosis. Okay. I mean, even in the best of the reconstructions, the flap reconstructions which we do, we are not able to clear off the entire adenomyosis. And I think this is one point which anybody who has seen even a person of my caliber operate will agree to that. Correct, Aarti madam? Right?
Absolutely.
Right. The second thing which is very important is many, many times when you are trying to close off this tissue, okay, the margins of the adenomyosis, what typically happens, these margins are very, very tough. And even if you are the best person, these margins are very difficult for you to close. Okay. So just doing adenomyomectomy, that is why a lot of people they refrain from doing adenomyomectomy as a part of their surgery. You know, they will always pop up some stupid guideline that acha, you should not do adenomyomectomy when you do endometriosis surgery. You should not do that. That is because they are worried that when they close this adenomyosis and if they close it wrongly, it is going to have a negative effect. What is the other important thing that we need to remember? The beautiful injections which are currently available, like Zoladex, even our protocol, letrozole plus regesterone, which we have popularized across the country. Let's say Lupride Depot. No matter whatever you give, this is not going to work when the uterus is more than 10 centimeters in size. If the length of the uterus is more than 10 centimeters in size, this is not going to work. Of course, in a country like India, where people want to experiment with patients, you will easily see patients at a uterine size of 12 centimeter, 14 centimeter, all of them being given Zoladex with the hope that, you know, it is going to go down, but nothing happens. And majority of these patients are either going to end up as completely infertile, and majority of these patients will ultimately end up with surrogacy. Okay. Now, when they end up with fertility, and an adenomyotic uterus, one should remember there is a huge risk of developing recurrent abortions in this situation. Okay. Now, we ourselves, if you see our past history of doing such huge volumes of adenomyosis and such huge volumes of redo adenomyosis, so we have had and we have posted and we have shared countless stories over the last few years of patients who have undergone an adenomyomectomy with me. Okay. Large uteri, they have undergone an adenomyomectomy with me and they have delivered. And in all our sessions, we have given one very important message is that if the endometrial myometrial junction is good, basically it is differentiated. Okay, that is when the patient is going to have a benefit of any of these procedures. Right now comes in microwave ablation in all of this. So, as Aarti madam has shown us, this is where the adenomyosis is going to be present. Posteriorly, predominantly, it can also extend centrally, it can also extend laterally. Okay, but because we are doing it in 2D, we are going to be describing it in this manner. Okay. So what is microwave ablation? Let me just write down. This is so easy. If I hope my YouTube channel, because it's a popular one, there could be many housewives watching. And you know, microwave ablation is basically microwave. Okay, so what is microwave? It is what current? It is a EM, electromagnetic current. It is a wave, no? So the EM waves are passed inside through a probe. Okay, you have a probe here which is going to go inside the center of this. It is going to pass microwave current. So it is going to heat up and it is going to liquefy the tissue. The good thing about this form of an electromagnetic current is that it is very fast in nature. Okay, the heating element, it reaches a very high temperature very fast. That is why when my mummy tells me, or when my wife Rajvi tells me that go down, boil milk for children and come when they are, my children are small, by the way, 7 years and 3 years. So when I go to boil milk for them, I put the milk in the microwave for only 1 minute. And when I take it out in the microwave after 1 minute, that milk is nicely heated up because it has reached a temperature of more than 100 degrees. So the milk gets heated up. The same thing happens inside the uterine cavity, in the uterine musculature as well. All right. Now, this is something which you are going to achieve as a form of microwave ablation, and you are going to cause a good amount of reduction, okay, in the volume of this unhealthy adenomyotic tissue after you go and burn this tissue, after you go and ablate this tissue. Correct. Just to show it to you little better, I'm going to so I'll just tell you, we do huge volumes of microwave ablation over the last 2 months in our unit in Bombay. And this week we've done 9. Okay. So I'm showing you the ablation which I just did. Okay. For a patient before I just came in. So I have not even got time to edit it. It is an unedited ablation procedure. I have shown a part of it on Facebook Live, but I'm going to show you the part with ablation as well as ultrasound. And remember, all of you, all of you are going to be able to see it very, very nicely. Okay. Just see this now. So Aarti madam, be online because I've connected this to my pen drive, you know. So right. So I think you can access. Can you see the photos, Aarti
Yes,
madam, by the way?
yes, can see.
Yeah, can see. Okay, guys, now please understand one very much unbelievably important rule. Okay, microwave ablation is a technique which will only work after you finish doing adhesiolisis. It is not a technique which is going to be working for your patient when you have not done adhesiolisis. So this is the patient. You can see the beautiful endometrial myometrial junction, madam. Can you see that?
Yes, the triple line.
It's a triple line, right? And behind that you will see adenomyosis. Now the problem with this adenomyosis is the patient is in pain. We have done the complete endometriosis surgery. That has to be done the first, huh? Matlab, you are not supposed to do a transvaginal, like how these people try to promote ethanol sclerotherapy and end up with an abscess. No, you, this patient also had a bowel resection today, by the way. Okay, there was a huge bowel nodule, and that is the Foley's catheter. There is a small fibroid. See, guys, we are poor people from Bombay. This is a standard HS40 ultrasound machine. We cannot afford, GE 22 series, all these types of things we cannot afford. But this basic ultrasound machine, so madam, you can see I'm probing something, right? That thing which I'm probing is the microwave ablation probe. Okay. I'm probing it through my laparoscope under ultrasound guidance. And now finally, I am entering inside with that probe. If you see, I will be able to show you the whole probe inside. Okay. And the probe comes inside. You can see that the probe is coming inside. You will have a feeling that something is coming inside, right?
Right.
Right. It is coming inside the uterus and Visma is down. So see that. That is the probe. Can you see?
Yep.
I've paused it. 1 minute. He'll give up. Yeah, I've paused it now. Can you see that thing in the center, madam? That
Right.
beautiful straight needle like white line, that is the microwave ablation probe. Okay, and this microwave ablation probe is basically then going to be activated. You can now see it in the posterior wall of the adenomyosis, far away from the endometrial myometrial junction. Correct, madam?
Right.
And now after the probe being in center, you will see us ablating the tissue. You will see it and you will see that, oh acha, like this the tissue is getting ablated. So you will see, you will realize how the tissue gets ablated. Okay, so first, guys, remember, First rule is do complete endometriosis surgery. This is the reason why ablation therapy fail and people worry about complications because they don't dissect it properly. If you do a good bowel adhesiolysis, bowel will not come in close contact. You have complications when bowel is in contact and serosa gets heated and bowel gets heated. If you do complete adhesiolysis, it does not create a problem. And this is something which is now going to be a globally accepted thing. We have discussed it with multiple experts across the world who are doing it. Remember one thing, for these techniques, it is China, South Korea, and Japan. Okay, we don't have to look at countries like America, Canada, and all these types of stupid countries. They are very, very backward when it comes to developing these type of exciting technologies. Okay, so there is the probe inside, and I think in this video you will see the ablation which is happening. In fact, if you look at the time, it is 8 o'clock 3 minutes. Huh? See now it is ablating. Can you see it, madam? Can you see the tissue getting heated up inside? See that white bubble like thing coming out?
Yep. Yep.
Yeah. So that is the ablation, madam. The whole thing will get ablated. See, and you will see centralized necrosis inside this, preserving the endomyometrial junction. Mind you, this probe is being put inside through the laparoscope. Okay.
So you've
So it is,
cap
yeah,
you
and you are seeing the ultrasound picture. On the other screen is the laparoscopic picture, which we showed live on Facebook today. So when you see this much ablation has occurred, let me just show you to the next part. Okay, see that the whole thing is now appearing white, no? That
yes.
white thing, and see above that is the endomyometrial junction. I'll show you. See above that in this frame, madam, you can see the endomyometrial junction, correct?
Right.
Right. So this probe has come inside. Let me just fast forward it a little because this is a live video. So what typically happens is we are doing everything live and showing it. Let me just fast forward it for the benefit of the audience. Yeah. Now see, we went into a completely different track. Can you see the needle at a different track now? We went into a different track through the same incision and we will ablate more of the tissue. Now I am close to the endomyometrial junction. So some operators recommend that you are supposed to put a Foley's catheter in the endometrium and pass cold water through it. Remember, this probe has cold saline passing through it in order to prevent heating. Understanding this, the machine itself is calibrated such that it has a cold saline passing through the probe. The same probe, no, you can put a Foley's bulb inside the endometrium and pass it cold water. But we are not doing it because now I think we have achieved certain amount of expertise where you can see now. See, it has started to ablate the tissues there. Can you see? That thing is turning white. The whole thing will turn white now. Understanding? And now we have reached a good amount of temperature calibration with our dexterity that we are able to ablate these tissues very fast and come out. So, Aarti madam has asked one question inside this. Okay, but we are worried about the long-term outcomes and the immediate outcomes. That is a correct question. You should be worried about it because there is not much data available on these things. But we want to tell you that we have even done embryo transfers in these patients because we have been doing this since around 2 months. We have done embryo transfers in the patients. Patients are pregnant. There is no problem. You are going to have a volume reduction of approximately 40 to 50%. Okay, in the next 45 to 60 days following this. At the end of this procedure, we don't really want to give any form of hormonal therapy. Nothing like that we are supposed to give. See this ablating happening. Can you see, Aarti madam? That whole tissue is turning white. You can see the whole tissue turning white with air bubbles inside. You can feel that thing, no, getting ablated on the live video, isn't it? Can you see that, Aarti madam?
Can see.
Yeah. And again, I'll fast forward this a little. So I wanted to show you one beautiful post-ablation image of this patient. I think it is in this video. Yeah, I think it is in this video. Now see, majority of the ablation was actually performed. There is this little speck remaining. I wanted to show this to you. See, Aarti madam, can you see that necrotic area in the center? See.
Yes. Yes.
Can you see that, madam? That
Yes.
necrotic area which just passed by? I'll
Right.
show you 2, 3 more of these necrotic areas. See what has happened is this part has already undergone central necrosis. Understanding? Once central necrosis is finished, I want to show you. Wait, little fast forward I will do. Yeah, I've even actually pointed it out there. Yeah, this now you will see. See, it is so beautiful. Can you see that? Can you
Yep.
see that area of central necrosis
Right.
with that
Right.
white
Right.
rim? Can you see
Right.
that, madam?
Right. Right.
So it is that white
Hyperemic
rim
rim.
which, yeah, it is that white rim which I have protected. Understanding? and rest everything I have ablated in the center in a radius of around 2.5 centimeters. And now we are doing things even better. See, we are going close to the absolute base where the cervix is there. Can you see this, madam? My probe is now, my ablation probe has reached the cervix,
Mhm.
just above the cervix, when you have this bad endometriosis, and we are even fulgurating the endometriosis and adenomyosis from there close to the cervix. See this, just watch this for the next maybe less than 30 seconds and you will see this. Saw the ablation, madam, how it
Yes.
happened, and see how the entire junction is preserved. See, I'll show you how it's preserved. See this, 5 seconds. See, the whole endometrial stripe is preserved here. See,
Mhm.
saw that?
Mm. Mm.
Nothing damaged. Now, of course, this type of expertise, if in case somebody has to reach, you will require a lot of technical skills because you are using an ultrasound from below and passing a needle from the laparoscope above. So there are a lot of technical requirements and adjustments which you will have to do in order to pass it very, very nicely. Understanding? 1 minute, I'll just show you the final picture. This is the final ablative window where we ablated close to the cervix. I was just talking about this. Can you see that? My probe is inside and I'm going to begin the ablation, I guess, here. See the ablation now. Can you see? It turns white, madam. Can you see?
Right.
It's like a microwave, it turns white and the whole thing close to the cervix. I'm so just supracervical, if you see.
Right.
Okay. And I'm ablating the whole thing supracervically, and it is getting ablated, it is getting necrosed, and I am doing nothing to the endomyometrial junction. Just see that. The endomyometrial junction is intact. You'll see that. Can you see? See, the whole junction I have kept intact, right? So
Mm.
this is basically your entire sort of therapy as far as microwave ablation for any of these patients is concerned. Of course, you must remember one thing, that majority of these ablative procedures have to be carried out with the laparoscope. So I'll just give you some guidelines to that. When you put a laparoscope, primary step is to do adhesiolysis.
Mm.
Second, if there is a nodule, remove the nodule. Arti madam is a superb champion now at using staplers. She only puts the staplers through the rectum. She only destroys the hell out of those nodules. So Arti madam now clearly understands how important it is to knock out these nodules, because we have done huge number of bowel resections in Hyderabad unit. Okay. And that is something which is important because that is a very important thing. Okay. Once you do the complete adhesiolysis, do peritonectomy and ensure that the ureters go lateral. The ureter should not come into this window of firing and window of heat at any point in time.
Mm.
You guys, we normally give a steep head low and we operate the cases at approximately 11 to 12 millimeters of abdominal pressure. When you put the ablation probe, put the pressure down to around 5 millimeters. We will, I mean, 5 millimeters of mercury. So the abdomen will be less tense.
Mm.
Why? So that experts like Aarti madam, Mamta madam, Vismay, all these people, when they are sitting on the vaginal end and they are showing you transvaginally, that gas level is less in the abdomen. So visualization of the uterus becomes easy for them. That is a very important thing. We normally fill up the entire pelvis with water, saline, just cold saline, and then we put the ablation probe. So what happens is any air pockets which are remaining in the pelvis don't remain, and you just have saline.
Mm.
Okay, which increases the visualization of the uterus and makes our efficacy of doing the ablation much, 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 much more refined and much better.
Mm.
And finally, remember, you will need some training, you will need some hands on for this, and you will need a huge amount of dexterity to go in the right plane. Majority of the time, people will go in the wrong plane. Because they are in the wrong plane, they'll ablate the wrong tissue and come out.
Mm.
Okay, so what we do is we will always do a hysteroscopy before the procedure in order to ensure if the endomyometrial junction is good. Remember, if the EMJ is good, the hysteroscopy findings are good. If the
Mm.
EMJ is bad, on the hysteroscopy findings, you will see those adenomyotic nodules. And you will know that even if you do the ablation will give a lot of pain relief, but the ablation will not give the patient an excellent fertility outcome. This is what you are supposed to tell your patient when you counsel your patient. Okay. One more thing we must remember about ablation is that it is not going to, you read two papers these days. Everybody these days, how the quality of patients is. They will read one paper, sample size is 12 patients, and they will say that it has been reported that, oh, there are bowel complications. Correct? Guys, there are bowel complications even when you put the trocar. Does it mean that you will not put the trocar? There is a complication of fluid overload in hysteroscopy. So does it mean that you will not do hysteroscopy? Understanding? As I told you before I conclude, for every new procedure, there will be 98% of the people who will tell you, don't do it. Correct? The same thing. If anybody of you is a gynecologist and who is watching this, and you are going to go through the journey, just go through the journey 20 years back. 20 years back, nobody believed in laparoscopy. The guys who did not learn laparoscopy and did not believe in laparoscopy are nowhere in the horizon now, because laparoscopic surgery has become the gold standard. Correct? I am not saying microwave ablation will become the gold standard. I don't mean to tell that. All I'm trying to tell you, it is an exciting technology. It has to be tried on well selected patients. You have to learn to do it, because for patients who are desirous of fertility, remember, doing surrogacy is getting very, very difficult. Very difficult in our country. So, what is going to happen is, you require a uterus which is less than 10 centimeters in maximum dimensions, length. You require a uterus which is less than 6 to 7 centimeters in width. That uterus will accept an embryo and allow a pregnancy to carry on till term. The confidence which you can give to your patient that I'm not going to damage your serosa, because if you keep the serosal musculature intact, the risk of rupture uter goes down. If you ablate, remember, ablation not just destroys the tissue, it also destroys the abnormal neovascularization. That is how heat is. Because you have destroyed the abnormal neovascular tissue, it is important that you may end up improving the endomyometrial junction. As a result of this, it is a great therapy when somebody is desirous of fertility. If somebody is having only pain, does not want to have children, wants to conserve the uterus, why bother? Just do adenomyomectomy, bin das. She does not want patients, knock out 80% of the uterus. But if she wants to have a child, you should not just preserve the uterus, but you should preserve the uterus in such a manner that when this uterus goes to 36 weeks, 37 weeks, 38 weeks, there is no rupture. You should preserve the uterus in such a manner that the neovascular channels of adenomyosis get ablated, which improves the endomyometrial junction, which reduces the IOGR. Okay. I don't have papers supporting this. You all know I am very poor at publication. Correct? One day I may publish. Okay. Somebody has given me a beautiful email, but that guy is charging 1 lakh rupees for one paper. I might as well buy some belts. These days I'm very excited about doing shopping. Okay. So what is important to understand is that one day somebody will publish this. But I think this is a good technology. You should do it, and at least you should counsel your patients that something like this is available. Because if you are unable to counsel your patients, these days the internet is flowed with these things. I published an Instagram reel on microwave ablation which has got 10,000 views. Okay. So you really need to get into this system. It is a good thing. I think it is a good thing. One thing I'm telling the audience is that we are going to start doing this at Bangalore, Hyderabad, Chennai, Agra, Ahmedabad, all places, because we have seen very good results. We've seen very good results because we are meticulously doing the surgery. We are not just putting the probe and coming out and then complicating. We are doing the whole thing first, and then the last small part of the surgery is microwave ablation. Microwave ablation is mm, not the everything of the surgery. The everything of the surgery is the adhesiolysis. People have to understand this. Okay. With that, I conclude. Aarti madam, some more questions and I'll answer.
There are lots of questions. See, since we were talking about the procedure over here, I think many of us are having the same query, that how do you avoid, getting to the endomyometrial junction and actually
Yeah,
burning it off? So
that's
how
a
do
great question. So you have two options, as I told you. You can put a Foley's bulb in the in the cavity, so
right?
you will know where the cavity is. That is
Mm,
option number one. Second, now with that ultrasound guidance, no madam, when the probe goes inside, I have a visual feeling of how much ablation radius it is.
mm,
Understanding? So even before it goes and touches, I will always stay approximately 5 to 8 millimeter away from the EMJ. When
Okay.
it starts to reach there, I will stop the ablation.
Okay.
Understanding? But
Okay.
now it is for me, it is a visual feedback mostly,
Okay.
considering my volumes.
Okay. Okay. So you're around 8 mm away from the junctional
5 to
zone.
8
Do
mm.
you
Yeah,
take multiple incisions, especially
multiple.
the bulk
I
is
take
high?
multiple. I take multiple because most of the patients whom I am doing are bulky adenomyomas, madam.
Okay. And how deep do you go from the serosa, at least minimum? Because again, if you're too superficial, you're going to damage the serosa.
The probe, you have to put the probe around 2 centimeters deep, madam.
Okay.
Minimum 2 centimeters. You can
Okay.
go even more.
Okay. And usually, how many times or how many incisions do you make throughout, say, for a 10 centimeter eddy? What is your minimum cutoff for
So,
doing?
madam, we now, myself and Vismay have developed something called as an adenomyoma map, where
Hmm,
we will map it in cross sections.
hmm,
Understanding?
hmm,
And once we map it in cross sections, we will go every 2 centimeters from right ovary to the left ovary, like that.
uh-huh.
Understanding? So we'll put our probe at every 2 centimeter intervals from right side to the left side.
Okay.
And we will also put our probe every 2 centimeters above. So first we go 2 centimeters below, stop the ablation, take it out by 4 centimeters, again ablate if it is in the tissue. It will again burn another 2 centimeter radius and 2 centimeter radius below. So it would have knocked out that entire tract, again go up like that. So now we have developed a map of doing this, which we will explain. Next video, we'll show you the whole map. It's very easy to do. Imagine I can do it. So it's a very easy thing to do. No need to worry.
Because you can do it, we have to imagine, no?
That's also true.
And what about focal versus diffuse adenomyosis, Jay? Is
It's
there a
very good for focal adenomyosis. The only place where we are not recommending it at the moment is focal adenomyosis of outer myometrium. That is
difference?
because that adenomyoma is located 2.5 to 3 centimeters usually away from the EMJ. So
Hmm.
for that, excision is the treatment of choice, not ablation.
Okay. And what about difference in outcomes for anterior wall versus posterior wall
Same,
adenomyosis?
same.
Nothing.
No difference.
Who not to offer it to, Jay? It's easy to offer.
Focal aden focal adenomyosis of outer myometrium don't offer. 100%. No ways you should offer it. Right? Another important case where we think you should not offer is when there are multiple myomas with adenomyosis.
Right.
That is a case where you should not offer. Listen, I am not doing, I know people, our colleagues in China are doing ablation for myomas
Mm-hmm. Hmm.
and they have excellent outcomes.
Hmm.
But I think in a country like India, if there is a fibroid, you should remove the fibroid. I mean, you know, I am more pro myomectomy. So, multiple myomas with adenomyosis, I don't offer. Focal adenomyosis of outer myometrium, I
You don't.
don't offer. Any uterus which is any which way is less than 8 centimeters,
Right.
having a small focal adenomyoma, no need to do all this.
Right.
This is going to help a patient whose uterine size is basically more than 9 centimeters.
Okay.
100% it will benefit for size more than 10 centimeters. Sure. Understanding. Let's say somebody has a uterine size of 12 centimeters.
Hmm.
This will benefit. Don't worry. This will benefit. There will be degenerative changes which will occur in the myometrium.
Hmm.
Correct? There will be degenerative changes. 100%. There will be degenerative changes. The body, the uterus will undergo remodeling.
Hmm.
Understanding? We have seen that. We have followed up our patient from 4.5 months. Every 2 weeks, we are calling them for a free sonography.
Hmm.
Understanding? And they are coming and doing those sonography, and our boy, our humble boy, is spending approximately 15 minutes looking at every uterus inside that. Every fiber he is looking. Okay, so what we have realized is no, after this white ring which you saw,
Right.
this
Right.
white ring after 2 weeks will get a little edematous.
Hmm.
Understanding? You will feel, Array, what is there in the uterus? But
Hmm.
there will be no adenomyosis.
Hmm.
After that, the patient, see, nothing is going to happen in menses because the patient will, there is nothing in the endometrium. So menses will be fine.
Hmm.
Understanding? But patient may sometimes experience after 3 weeks, 4 weeks, 5 weeks, 1 or 2 days of spasmodic dysmenorrhea.
Hmm.
Little dysmenorrhea when it is getting absorbed.
Hmm.
Understanding? Once that thing, and it is only for a day or so, we have seen it in around 7, 8 patients. Understanding? They don't need hospital admission, but they will call you up. कि सर मेरे को एक दिन पेन हुआ था बीच में I mean, they'll tell you that मुझे एक दिन pain था, and
Hmm.
that's about it. Then no, you will see in 2 months, let's say a 12 centimeter uterus will go down to around 9 centimeters. It is not going to go from 12 to 2. Huh? That is not your target. Normal uterus is 8 centimeters,
Hmm.
7 centimeters. So your target is it should become from 12 to 9. You
Hmm.
are not going to be able to make it 12 to 7. That's not going to work.
Hmm.
Okay. But one good thing happens. Okay.
Hmm.
This is just my, I mean, very personal experience. I mean, I don't know the reason behind it. Understanding the endometrial blood flow improves
Hmm.
post this procedure.
Hmm.
Okay, the endometrial lining becomes beautiful triple line.
Hmm.
All this lupride, fupride, even letrozole plus resistone. See, majority of our patients are my patients who are on letrozole plus resistone.
Hmm.
Understanding whom we have counseled for this.
Hmm.
Okay,
Hmm.
whom we have taken signatures that look, boss, at the moment in India, it is an off-label indication. When I use microwave ablation for lung and liver, I am
Hmm.
justified. It's
Hmm.
an insurance covered procedure.
Hmm.
Microwave ablation for uterus currently not insurance covered, but we have filed application with 7 companies. So I
Hmm.
think we will be able to get it from those 7 companies in the next 3 to 4 months, and then it will become covered in insurance, and people will get reimbursement for
Hmm.
this procedure. Okay, so that we have taken some efforts to do all those things, but there will be a bunch of patients where you may think that this has not worked initially. You will feel that. Even I felt it for after my first 3 4 procedures,
Hmm.
but then I realized that you need to, the effect of ablation starts to come after 3 to 4 weeks, when that entire fiber undergoes lysis, no, completely, and then the body absorbs that lysis, no. That
Hmm.
is when the serosa comes and gets stuck there. So you
Hmm.
will have that little wobbly uterus initially if you
Hmm.
have not ablated properly, and then you will have a very good uterus.
Hmm.
Okay, in 2 months. So what we recommend now to patients is that once you do a microwave ablation, you hold on for maybe 2 cycles, 2.5 cycles, 3 cycles, and then do your embryo transfers.
Okay. Okay. And when do you expect pain relief in these patients? Same 2.5, 3 months?
There is not so much pain, madam.
No, relief. Suppose a patient wants it for dysmenorrhea.
Oh, very good. It's, I can't tell you. It's very good for pain relief.
Okay. Is there an upper cutoff? Like you were just talking about who not to offer it to. So you said minimum 9 centimeter and you said 10, 11, 12 is good. Now suppose you have a 13, 14, 15 centimeter.
See, the max I have done so far,
Right.
okay, max
Right.
I have done so far is 16.4 centimeters.
Okay.
Uterine length, huh? Uterine length.
Okay. More.
And she is 1 month post procedure,
Okay.
and 16.4 has become 15.2.
Okay. Okay.
I don't know how much time it will take for 16 to become 9. I don't know that.
Okay.
Okay, I am happy with this 12 13 centimeter window, madam, because this 12 13 centimeter window, I am an expert now. I can go 1 centimeter, 2 centimeter, 3 centimeter, and even before the probe comes out, no, I would have ablated the entire tract.
Okay.
Understanding, in 3 3 minutes, I will ablate the whole tract. So I am very good at it now. Now after doing so many.
Okay.
Okay, for a newcomer, they will not know only where the probe is. That is the problem.
Okay. Is it true that the higher the age, lower the estrogen, the tissue tensile strength is lesser, and so the energy which needs to be applied should be lesser for an older woman compared to a younger woman?
Adenomyosis is altered tissue.
Right.
It is not uterine tissue. It is
Hmm.
altered uterine tissue.
Hmm.
So I don't know the
Has
answer to that.
no age has no effect on
No,
that.
no.
Okay. And what about comparison to other modalities of treatment
I mean,
in term
you
in
can't
terms
really
of
use HIFU for ablating adenomyosis. I mean, uh, it's gone out of wig,
right,
right? You
right.
can only use microwave ablation because that is the best available device at the moment, which
Okay,
works inside the uterine musculature.
okay. And what about the real complications, Jay? The
Real means,
complication, real matlab what you have faced. See, there are lots of
so
terrifying things
I,
about
yeah,
ablation
yeah. No, no.
there.
Internet will tell you any type of shit, but
Right.
I'll tell you what happens. The most funniest thing which we have faced. Okay, so if your ablation window is not correct, okay, then the patient keeps on developing fever,
Hmm.
because this lytic material, no,
Hmm.
this lytic material, I think can get infected and you can have pus inside.
Mm,
Okay.
mm,
We have never had it so far. So far, we have not had it in any of the patient. I think the reason why we don't have it in any of the patient, okay, and again I could be wrong, is because we dilate the cervix to 8 dilator, then we put the hysteroscope, okay. So even if there is a small lytic material somewhere, the uterus is so good that it will make a hole in the endometrium and it will throw it out. Understanding?
mm,
Or it will throw it in the peritoneum.
mm,
The other thing which one has to be careful about, very careful about, I'm again repeating this, is adhesiolysis. Please make sure that your adhesiolysis is fabulous. Understanding? It has to be fabulous. Okay, one more thing. We don't even give antibiotics for more than 5 days, madam. Post procedure, our post procedure for a patient with microwave ablation is augmenting paracetamol, pantocid. Okay. And for some patients who may experience this pain, we are giving them chimoral fort. Okay, it's chymotrypsin, just in case some lysis has not happened correctly. But we have not had patients who have used chymotrypsin for a month.
mm.
Nothing.
Okay. Do you usually just complete this whole ablation in one sitting, or there are patients
One
where you
sitting.
require multiple sittings?
You
Actually,
will
Padmapriya
never know,
also
madam.
like,
If you try to put a probe next time, no, in that same uterus, it has never happened to me so far, but because it's been only less than a year since me doing it. So if you try to put in a probe, no, in any of the other patients, madam, in these type of patients, that thing would have got lysed inside. So you will not know if you are lysing the already lysed thing or if you are lysing a new tissue. It's very tough to predict.
right. So just one sitting is what you've always done. You've hardly
Do
required an
do one fantastic sitting.
right, right. And what about recurrence? Of course, it's too early. And anyway, you're not completely making the uterus normal. It's just bulk reduction that we are doing.
It's for fertility.
Right.
It's for reducing the bulk. Patient may have a recurrence once they are pregnant. Patient may have a recurrence, let's say 5 years down the line, but I don't have a 5 year follow up, so I can't comment on it.
Okay.
And I
So,
don't go by papers which are published. Remember, guys, you are treating Indian women. Indian women are going to behave differently than, let's say, Japanese women.
mm,
Correct? Please
mm,
don't compare these studies and extrapolate. अच्छा फ्रांस में ऐसा हुआ तो इंडिया में भी ऐसा होगा. Nothing happens. Indian women behave differently.
right. And after the surgery, do you give any agonist or letrozole and
It's not needed.
nothing at
It's
all? Just leave them alone.
madam, by the time a patient opts for microwave ablation, you think in a country like India, anybody will spare them of Zoladex?
True.
I mean, people will give them a bath in Zoladex, understanding. But Zoladex is all our patients whom we have operated, no, have at
Right.
least taken 3 4 shots of Zoladex, and they are frustrated because they've changed 2 3 doctors. He has also given a different brand of Zoladex, understanding. But Zoladex is not going to work beyond 10 centimeters. It doesn't work.
Any post-surgery, do you want
Nothing, nothing,
nothing at all?
nothing.
Okay. And just another last two questions. Actually, even Padma Priya is online. You can just unmute her, Jay.
Oh my God. I
Yes.
love her so much. She's my Da Vinci. Let me see. Where is she?
Hello, hi guys. Very nice session. Actually, I
Oh
wanted to, yeah, I
my
really
God.
wanted
Dr.
to,
Padma Priya is watching means the microwave ablation sales in India will skyrocket now.
yeah, right. No, I'll keep patience. Yeah, I really wanted to. All the questions I wanted, Aarti answered, whether the second session is needed. Very good job, Aarti.
We don't know, madam, currently if the second session is needed or not needed, because even I have never had to repeat an ablation for anyone. Okay.
Mhm.
And we have got post embryo transfer pregnancies in this, and pregnancies are continuing. So I am only going by that feedback that the pregnancies are continuing. If the pregnancy continues, that means, see, remember one thing. As I told you, I irritated the hell out of Xiaoming Gong.
Mm,
Okay, he is our Chinese colleague. I think the amount of irritation I gave him by
mm.
asking him questions, China might as well ban me. China will never allow me to come to China, they will never issue a visa to me. Okay, because I questioned him so many times. I also spoke to the guys who manufacture this machine in China. This is a machine which is manufactured in China. So I spoke to those guys. Okay. It so happened that they had invited me to their province in Shenzhen, and as usual, Chinese government did not give me the visa only, so I could not go. Otherwise, I was supposed to go there and pick up the machine from there and get it in our country in 2023, but that did not happen. So finally, they couriered the machine and all these things happened. But I want to tell you one thing: the calibration of the machine is very important. See, you have to calibrate this machine for Indian women. What they use for Chinese uterus, which must be eating lot of noodles and chopsticks and rice and this type of diet, is different as against Indian women who are immersed in rice all the time. Correct? No. So this uterus of an Indian uterus behaves differently than what their architecture is. So now I think over the last 30-40 cases, we have calibrated it for Indian women, and which is why our outcomes are good, is what I think. And I could be wrong. This is just Jay Mehta theory, and it deserves the right to be wrong. Something like that.
So you've calibrated it with the technical team of who's provided the
Yes,
machine.
yes, yes. With the technical team, that how much wattage should I keep? How much should be the calibration temperature when I put the probe inside? Remember, the probe has to be cold. It gets heated very fast. So the
Yes.
probe has a water channel inside where cold normal saline is flowing in through it.
Okay.
Understanding? And we have calibrated the temperature that, okay, I think this is the best temperature. Something like that.
Okay. Okay. And I think the last burning question is what is the cost of the procedure and what is the cost of the machine?
It's okay. Why should be worried about the cost of anything in life? You know,
They want to
remember.
invest, no, Jay? Or they're
So,
thinking of investing. So is it worthwhile?
so one must remember one thing. You should buy these machines for the love of these machines. Understanding? You should never think about what is the cost of these machines as long as you think it may benefit your patients. Second, the cost of a single probe, which is available, is approximately 1,45,000 rupees plus GST. Single probe, single patient.
Hmm.
Understanding? What we normally do here is that we have bought these probes in bulk. Okay, so when we got the machine, we asked them how many probes do you have available in India. They said we have 8. We said we'll not buy the machine. You send us 40 probes. Only then we will take the machine. So they are like, nobody has placed an order of 40 probes in India. Okay. So I said, but I am me. You send me 40 probes. Okay. So when we bought 40 probes, the same probes which are otherwise available at 145 as MRP, we got it at some 1,04,000 or 1,05,000. It makes a difference. See, when you reduce 30,000 rupees from the cost of the surgery, we don't charge anything for the machine at the moment. We don't charge at all. Okay. Because we are taking consent as an experimental procedure. At the moment, we are taking consent as an off label procedure. That rest of the surgery we are charging very nicely. Understanding. But we don't charge the patient that, oh, I am doing microwave ablation, 5 lakh rupees more. We never do anything like that. We tell them that the probe is this much. You will have to pay for the probe because we use the probe, and they are happy to pay. 99% of them are happy to pay. So far, we have not got into the system of reusing the probes. I would not encourage that at all because it goes inside the uterus of some patient, and you really don't know what type
Correct.
of things must be present there. So we have not done that so far. But at the moment, so what I have got into a contract with the company is that every software update for the next 10 years, okay, they are going to give it to me for free.
Hmm.
All right, because every year, every 6 months, they will be updating their AI. The new probe which they have launched is a probe which has a little that tip, no? When it goes inside, that tip gives that little haptic sort of a feedback that are you in a good area, are you in a bad area, are you in an endometrium, how sensitive that thing is, how close you are. So all those new things will come. Remember, it is like a mobile phone. Every year, iPhone 14 will become 15, will become 16, something like that, right? So this is what I have done. This is the deal which I have cracked. Okay. Mm, and forget about the cost. Just remember it is not as expensive as Porsche.
Perfect. I think you've given most of the answers, Jay. Such a controversial topic, but you have simplified at least our understanding. I think time will tell whether it's going to work in all our hands. Of course, you have a great experience, but at least
I
you have.
personally, if I can add a very bad statement here, I personally think, madam, it will not work in all the hands. This is one machine which does not have a reproducible technique.
Mm-hmm.
This is one machine which is completely, which cannot be replicated. I'm telling you.
You're talking about the technique
Imagine,
of doing it and understanding
because
how
of the,
much to burn and how
yeah,
much.
because of the technique of doing it, no, even if you see me doing it, you will not be able to replicate it. And we have experimented this, okay? So we have had cases where I have told Vismoy to go and ablate, okay? And I am holding the probe from below, and he has held the probe from below, and I am ablating, correct? And there is a difference. So in my opinion, this is not at all a replicable technique. This is an operator driven technique. So if the operator is a very good operator, he will do an excellent microwave ablation. It is simply like interventional radiology, right? In interventional radiology, under CT guidance, you need an excellent interventional radiologist to go inside that plane, micro, I think Dr. Padmapriya will know what I'm talking about. And
Yeah.
interventional radiology department is one place where even if you have the best machine, but you have a stupid interventional radiologist, all procedures will fail. And
Correct.
it is one department where you, even if you have a little lesser machine, but you have an expert hand, their hand movements are so fine. Have you ever seen an interventional radiologist move his fingers? Their
Yeah.
motor control, the tip of finger motor control is fabulous. Understanding? And if you have that motor control to just angle the probe a little, tilt the probe a little, just pick up the probe by a little, that little things, no, makes a big difference in microwave ablation, is what I think. Okay, this, and again, I'm not trying to discourage anyone, I'm just sharing what is my experience.
Right. But one disclaimer here, Jay, most of your techniques are not reproducible. Most of your techniques.
See, that could be, but this, people can learn hysterectomy, madam, if you watch my videos. Correct? People can learn hysterectomy. People can learn, let's say, I don't know. I can tell you a similar technique which cannot be reproducible is alcohol sclerotherapy. Oh my God. What beautiful complications I have seen of alcohol sclerotherapy when people do it transvaginally. Because they don't want to do it laparoscopically. And because they are scared that laparoscopic adhesiolysis won't be correctly done, so I will just take an experiment and do it laparoscopic, I mean, do it transvaginally, which is wrong. Understanding? You call somebody, get them to do the adhesiolysis, and then you put your heart and alcohol inside the cyst. Do what you want to do. The same thing happens with ablation. Again, I am telling this the fifth time I am telling. If you do an excellent adhesiolysis, all the other vital organs of the pelvis, the rectum, the ureters, are far away from your ablation margins. And even if there is a heat which is developing at the uterine serosa, which it doesn't develop because we are putting fluid, so we'll come to know, if it is getting warm or not or whatever. And the conduction of electricity and heat becomes lesser when you have pelvic fluid. But the primary thing is you do adhesiolysis.
Super.
Okay, that is the primary thing.
Right. So I think, Jay, great take-home points, and at least we now understand who to offer this to and who not to, and how it is so operator-driven. And excellent take-home points. And I think it's now late. It's almost 1 hour since we've been talking. We didn't realize how time passed. And thank you. Yeah, it's already 11:10, so it's almost an hour.
This
That
is
was
the problem which happens when people who are doing this procedure speak about the procedure.
because they're so passionate about what they have done, what they understand, and you want to convey this sort of a message and information to all. So thanks, Jay, for this. And I think we'll call it a night now. We'll call it
Yeah.
a day. And good night for everyone.
Good night. Yeah.
Yes, yes. Thank
Bye.
you.